I work for UC Office of the President. My role is in the Cyber Risk Program, which is a fairly new program for UC. Prior to that, I was the CISO for UC Davis Health System. And in my role, I lead the UC Health CISOs across the system, as well as system-wide in my cyber risk role. So just a little bit of background. I wanted to just touch on some of the sizing, just so you give us a little sense of context of what we're talking about here. So when we look at UC as a health organization, we're talking about over 3,600 beds. We've got 4.5 million outpatient visits annually. We annually have about almost 1 million inpatient days. We have 5 major trauma centers across the state. And looking at system-wide, we have nearly 200,000 faculty and staff. So there's a lot going on, a lot at stake. Of the UC Healths, we have the UCLA, UCSF, UC Davis, UC San Diego, and of course, UC Irvine. We include in our efforts the new School of Medicine at UC Riverside, and they are developing their program there as well. We saw a need at UC Health and really system-wide we need to increase our collaboration. We have to strengthen our partnerships across all of those different health systems across the state. We have shared goals, but we need to incorporate those goals and work towards those together. And to really be effective, we have to be common in those approaches and consistent in those approaches. We have a mantra that we use, and that is consistent and coordinated for our cyber risk. And then, obviously, having that size of an organization working together helps us to leverage that size and act as one large organization instead of 5 different health systems, so that we can do things to achieve savings in costs, savings in resources, and really just be more effective if we're partnering together and approaching things in a very common way. When we first got together about a year ago, we all said, you know, what are some things that are short term? What do we want to do right now to kind of get this thing going? And so really the first thing that we looked at was, what is our universe? What do we have at our different health systems? So we took a snapshot and looked at our different information security programs, and we said, what are we doing about governance, services, processes, technology, and staff? So every one of those 5 health systems came back with their information so that we could share and talk amongst ourselves about what are we doing. You know, it included elements that were not even under the security operations. So if you're in security, you know that you rely on IT across the board. You rely on your network folks, your server folks. It's not just one thing that security has to do. It's everybody. And then we did a self-assessed maturity level. So we talked a little bit, you've heard today about that maturity model. So we use that maturity model to do just a self-assessment, just a quick, you know, where we're at, what's our gut check on that? And then we knew that as we grow and improve, we can revisit those assessments. Another thing that we wanted to do is establish a risk reporting forum. So there again, 5 UC Health security folks coming together on a regular basis to talk about what are you experiencing at your location, what are you seeing? And having that weekly call, and that's the first thing on our agenda. What's going on? What do you want to talk about? There again, if you're collaborating and sharing that kind of information in a secure way, because we're all trusted individuals, we're all working essentially for the same goal, we can share those things that we're seeing, and it helps the other location say, oh, I'm going to look out for that too, or yes, I've seen that, or you know, whatever the dialogue is. It's very important. Next, we wanted to look at what do we want to say are our minimum security practices? What do we all agree that this is sort of the least common denominator for security across UC Health? Now, at the time, the NIST CSF was still sort of burgeoning, so we didn't really pay attention to that. We looked at what was established at the time, which was the Center for Internet Security, Critical Security Controls. It essentially used to be the SANS Top 20, and you know, it morphed. So we took all those different controls, and we identified 17 minimum control areas with 47 specific controls. And these are just a few examples. You're looking at encryption, vulnerability management, incident response, endpoint security, security awareness programs, data loss prevention, many, many more. And having landed on those 17 control areas that we all agreed this is what we all should shoot for as a minimum, was really helpful to then say, okay, now where am I at, right? I will say that since our adoption of this, we've shifted to NIST CSF as the model for controls. So you're hearing a theme of that today, and there's a good reason for that. It is a good framework. And really, NIST CSF is the framework that is adopted system-wide for UC. So after we've got this minimum set of security practices, we need to say, where are we at? What are our metrics around measuring how effective those controls are? So because we were using the CIS CSC, so many acronyms, right? We wanted to grab metrics from that same body so that we were consistently looking at a control and an associated metric. And within the CSC, there's 96 available metric choices. So no lack of choices, but the problem is, as you heard just a few minutes ago, the metrics have to be actionable, they have to be meaningful. Just a metric for metric's sake doesn't really help anybody. So we identified 18 different metrics from those 96, and within those, they fell within 11 categories. So categories like malware defense, boundary defense. And we began to measure at each location and report out on where we were at with those different metrics. And then we have a need for common security technology and services strategy. So there again, talking about leveraging our scale across UC Health was important. And you have to have a strategy to do that. Otherwise, everybody's sort of solving problems in their own silo and really not communicating up or really not partnering or sharing how they're addressing or solving that problem. We wanted to purchase and utilize common security technologies and services as much as we could now without impeding the need to move quickly to address certain issues, but having a strategy to eventually get there, as well as services. So it's not just about, you know, the things that you rack and stack and power. It's things that maybe you're bringing in for assessment services or for you know, different outsourcing of and it's probably a bad word for UC, and I don't mean it that way, but you know, using an outside firm to help you do some services, but then sharing that across the UC Health. Next, we have the system-wide threat detection identification. So this is part of what my area of UC and the cyber risk does that also affects not just UC Health, but every location that we have a campus. We needed to come up with a way to consistently and coordinated, in a coordinated manner, address threat detection and identification across the system. Over a year ago, one location, UCSF, said, we need a way to have a security operations center. We need to have a way to identify the really true bad actors that are trying to get in and steal our data. What should we do? Well, they came up with this RFP to go out and get basically a managed service for security operations. That RFP resulted in, obviously, lots of folks bidding for that business, and we ended up selecting FireEye. So FireEye, for us, is now being deployed across UC at every location. It was a large effort to negotiate that. As you can imagine, with all those different locations, different budgets, we went through over a year's worth of negotiations to land where we're at. It's no small feat. We are slowly going through the statement of work processes with each location, landing on what their needs are, and working through even a size of something like UCLA, which is a very, very large campus, to something that's very, very small like UC Merced. All of them are going to go through this process, and some of them already have. We have an existing TDI vendor that does a similar process for us, and FireEye is replacing that vendor. So, other goals of TDI, common security technology and services strategy. You've heard that before. Now this is becoming a system-wide thing that we're trying to do. A system-wide cyber risk reduction, that's really the end game, right? Is reducing your risk. Identifying a baseline security posture across the system. Having a system-wide response coordination, so even though each location has their own incident response teams, and they are responsible for handling their incidents, when big things happen, when widespread things happen, we need to have a central way to coordinate that response. Metrics. Integration with location security tools when that's possible. So there again, if we have a system-wide TDI tool, those TDI tools have to work with location tools. So bad things happen, we've got to turn on some firewall rules, or we've got to look at improving our intrusion detection or intrusion prevention. There's a lot of integration there. And then integration with intelligence data. How many organizations are members with NHISAC? If you aren't, I encourage you to look at it. You're getting a lot of intelligence from health organizations across the nation that you will learn really, really good information about what the threats are that are out there. So if you don't know if your security folks are plugged in, maybe reach out to them. I'm not a cheerleader for NHISAC. They're just a really good, you heard about the ICELs and things like that. That's one organization of many that have some really good intelligence feeds. We're taking that intelligence and we're folding it into those tools, because if you know what the bad guys are doing and you know the specifics of how they're attacking you, and you can plug that information into those tools that protect you, it's a really good linkage that is constantly changing, daily, hourly. So I've gone through this a little bit fast, but I also don't want to have any gaps of time. If we have questions, I want to entertain those questions as well. So one thing about risk assessments that you've probably heard, you heard Mac talk about them, is if you really don't know your risk, you don't really know where to spend your resources, you don't really know what your gaps are. And for us, one of those risk assessments actually goes out to what we call our affiliates, and those are the folks who, they're small community hospitals. These are hospitals or even small clinics that can't afford or won't be sold an adequate, meaningful use certified EMR. You know, if you are a 5-person practice, Epic won't even take your phone call, right? They don't want to talk to you. But they encourage larger health systems that have an EMR to partner with them. And so across UC Health, we've been partnering with small affiliates, small community hospitals, small clinics. But to do that, as part of our due diligence, we've got to do a risk assessment of that affiliate. We've got to know what are we taking on. Even though we may not connect them directly to our network, they're having access to our data. They're having access to certain kinds of systems. They're logging into our EMRs. To solve that problem, you know, we've got to say, what is the solution to do risk assessments of those affiliates? Because we've got small affiliates, literally just a couple of folks, all the way up to community hospitals that, you know, might have maybe 200 beds. So there's a wide range there. And it's not necessarily true that the smaller clinics bring more risk because they don't have a mature program. Sure, that's an element of that. But also what you'll find, and maybe some of you folks here are in that same boat, even a 200-bed community hospital, they might have one person who's tasked with security, who's also tasked with patching their servers, who's also tasked with keeping the network up, who's, you know, it just goes on and on. This one person has all these hats. And it's unrealistic to expect that one person to be a complete security expert, also a complete server expert, also a complete Windows 7 expert. It's just not realistic. So in some ways, having that size of an institution who struggles with resources come in to partner with you, they might actually bring more risk to you. It's not absolute, but it's possible. It actually has that element to it because of the number of folks and the amount of data that they might have. So we've been working with a few providers to help us get there. We have to be pretty agile in how we do this because there again, if a provider says, yes, we'll do your risk assessment for $40,000, and we're talking about a 5-person clinic, the math doesn't really add up. So we have a few different approaches to that. Some are very small scale, like questionnaire type of assessments, and some are much more interactive, where we have people coming to an organization and looking at their security controls, asking questions, looking at previous risk assessments. So it spans that type of a range. And there again, we're talking about consistency. So if UCLA does their risk assessments this way with this affiliate, and San Francisco does it a completely different way, it's really hard to put all that stuff together and truly know what your risk profile looks like. So here's what I hope are some key takeaways for you all. Know your environment. What are you or what should you be protecting? This is a challenge. Having come from UC Davis Health System, knowing exactly what's on your network, that's very difficult. Not only knowing what's on your network, but knowing what your assets are. Where is your gold? Where does your PHI actually sit? If you've ever had OCR call you, they'll ask you, where is your PHI? You've got to have a good answer for that. That's not easy. I'm not here to tell you that this is easy work. This is not. This requires a lot of effort. This could require a lot of people. This could require a lot of expenditures and technology. But the fact is you've got to know where your stuff is. You've got to know what medical devices are out there. You've got to know their vulnerabilities. Hopefully your clinical engineering staff has some level of inventory to tell you, this is what we have in our environment. If you don't know what you have, how could you possibly protect it? So know what you've got there. Know your controls. If you're not sure whether or not you have a way to address a certain type of attack, you've already lost the game. So if your security folks can tell you, here's everything we've got, here's how it works, this is exactly what our gaps are, these are the things that we should be doing, you're in a good spot. Because trust me, it's better to know that, I think Patrick was saying, well, here's our roadmap or here's our dashboard of what we need to work on, and here's our plan, and he's got that whole plan. That's the best place to know is to know what you got and where you need to be. Because there again, if you don't know what you don't know, how can you possibly defend? How can you possibly react? It's an important thing. Just knowing your environment, having your folks know their environment is key. Know your risks. OCR will call you and say, I need to see your risk assessment. Meaningful use attestation, where's your risk assessment? Auditors, where's your risk assessment? If you've not heard where's your risk assessment, then you probably are not close enough to that question. But trust me, those questions are being asked. If you've not done a risk assessment in the last 12 months, you're woefully behind. The auditors, the regulators, all those folks need that. Now, is that why you need to do a risk assessment? Partially. But there again, that's compliance. Why you need a risk assessment, why you need a good risk assessment, is to understand a lot of the other stuff prior to that. What's in your environment? What are your controls? How well are those controls working? What are your true risks? If you know your risk, if you know your roadmap going forward to say, these are the things I've got to address, this is where we're not meeting the mark, that's what you can take to your boards. That's what you can take to your leadership. And you can say, here's our risk assessment results. This is what we found out. These are the things that we're just not doing correctly because either we just now figured it out, or, you know, we don't have enough people, we need some money to go to hire some folks, you know, we've got to spend some money on these controls. Whatever the story is, if you've got that risk assessment, it helps you know what your environment is. It helps you know where your controls are, what your gaps are, what you need to work on. It is essentially your playbook, if you will. And then finally, measure your progress. You heard some talk today about metrics. You've seen some of the things that we're doing at UC to do those measurements. There again, if you spend a lot of money, you've invested a lot of tools, you've got all these things going, but there's no way to really show how well it's working, it's not that effective. And it doesn't give you that credibility to go into the next time to say, I need some more money, because you've not really proven that what you've been given has been effectively used or utilized. It also helps you identify gaps too. So if you're measuring how well something is working or not working, there again, you can say, how do I need to improve that? What do we need to do to change that to be more effective? Or what else do we need to invest in to move that needle in the right direction?